December 7th. We're going to try and keep the meeting to about an hour, and we're going to have a lot of Q&A hopefully. So there's a chat function in the Zoom. I'd ask that you type your questions in there. We'll get to them at the end or whenever it comes into the flow of conversation. Make sure you're on mute. So if dogs are barking or things like that, it won't come up in our recording. We are going to be recording this, and this will be on Zoom, YouTube later. And you can find that at kcms.org website. We're going to go ahead and get started now. I'm Dr. Eric Larson. I'm former president of the Kent County Medical Society, joined with Dr. Nirali Bora, the director of the Kent County Health Department, and Dr. Will Nettleton, who is the director of the Kalamazoo County Health Department. And we're going to have a discussion today about everyone's favorite subject, unfortunately, this year, which is SARS-CoV-2 or COVID-19. And hopefully we learn some things, since now the vaccines are being now entering the EUA process, and so we should have them distributed soon. Just as a little background, I'm also the host of the podcast called The Paradox, Paradocs. You can get that in any podcast player. You can listen to me talk about other medical stuff. And our guest today, not only being part of the medical department, Dr. Bora, went to medical school, University of Michigan, family medicine residency at Brown University, and she had a degree of public health from Johns Hopkins, and she's been a member of the Kent County Medical Society since 2018. Dr. Nettleton is assistant professor in Western Michigan's Department of Family and Community Medicine and medical director of the health department, as I mentioned before. He graduated from Hope College, went to Wayne State for medical school, and did a dual residency in family medicine and preventive medicine and public health in Oregon, out in Portland. Board certified both family medicine and general preventive medicine and public health. And he serves as the 2020 president of the Michigan Association of Preventive Medicine and Public Health Physicians. This talk today is sponsored by the Kent County Medical Society and generous donations from the Kent Medical Foundation. And also, we'd like to encourage you, if you're not a member of the Kent County Medical Society or Kent County Osteopathic Association or the Kalamazoo Academy of Medicine, that you join and participate. We have lots of opportunities for collegial activities, and certainly in the Kent County Medical Society, if you're interested in serving in leadership, we have positions available. And nowadays it's all virtual, so it doesn't require much traveling. And anyway, I would encourage you to do so. And if you want to watch this video or previous fireside chats, which include discussions on grief, on racism, and on cultural issues, you can go to the Kent County Medical Society page at kcms.org. If you have any sort of questions, you can contact our office at kcms@kcms.org. There, if you have any ideas for future episodes or chats, we're trying to provide a way of just sort of staying connected and providing information that we think is interesting and useful for you in your practice or your daily lives. So with all that being said, again, I'd like to remind you to keep everything on mute and use the chat function. And as a final reminder, we will have door prizes at the end. So those of you who stick around are going to possibly win exciting gift cards provided by KCMS. So I'm going to put it back on my Zoom function so I can see all of your smiling faces. And I'd like to introduce Dr. Bora and Dr. Nettleton. Thanks so much for joining us.
Yeah, thanks
Happy
for
to be here.
having us.
So I'm going to start with the first question. Where obviously SARS-CoV-2 vaccines being rolled out soon. It sounds like any week we'll start getting this. So I guess what's the basic planning you've been, I mean, I know you've been, all you do is plan, right, at this point, but where are you right now as far as planning for the distribution and, how many doses we're getting, those sorts of basic questions. And I guess we'll start with you, Dr. Bora, and then go to Dr. Nettleton.
Sure. So mass vax planning is something that the health department has been doing forever. They still have all their plans from H1N1. And so we started meeting maybe about 2 months ago on a weekly basis, just to kind of discuss what we knew, what we don't know, because as you know, there's so much that's still unknown. And that's really ramped up in the past few weeks. We are now also meeting, we have an operations team just for vaccine planning, a team really dedicated to developing our in-house distribution, because we know that we'll be responsible for vaccinating EMS providers, and so and our own health department staff, and so making sure that we have everything in place from storage and documentation and staffing to do that. We're also meeting very regularly with all of our health system partners, FQHC partners and others weekly. This has been, I'm losing track of time, probably 6 weeks, 4 weeks, something like that. It's part of the West Michigan Vaccine Collaborative. And the goal of this is really to make sure that we all are communicating well through a variety of different partners. This also includes MSU, Grand Valley, a lot of other people too. 4 different health departments are involved. Mid-Michigan, Ottawa, Muskegon, others as well. So as we learn new information, we can share that information with each other. And so part of that has also been really discussing hospitals, because we know that the first allocation is going to be coming to hospitals as well as to local health departments. And hospitals will be responsible for vaccinating their own staff. And tier 1 of that includes general medical floor. So people who work anywhere in the general medical floor, in the ICU, in the emergency department. We will be taking care of the emergency through EMS. And then we know that long-term care, so skilled nursing staff and residents are also part of that first tier in that group 1A. And so that is a CDC and federal partnership to vaccinate those folks. So it's a lot of different meetings. We probably have 5 hours of meetings just internally on a weekly basis to discuss all the different parts and pieces to this, making sure that we know which long-term care facilities are signed up, thinking through some of those details. But communication is a big piece. And then I don't want to talk forever, Will, so I'll let you talk in just a sec. But the other piece is that we know that there's a lot of community trust that needs to, and transparency that has to be part of this. And so we are working with a group called Public Sector Consultants, and we've been doing individual interviews with community leaders from different racial and ethnic groups, including people with disabilities, to just understand what are people's concerns, what are their thoughts about the COVID vaccine. The next step from there is really connecting with more community leaders and community members to really think through what do we need to be sure that we are keeping in mind to be responsive to community needs and community trust. So I'll stop there. Go ahead, Will.
I think you hit the nail on the head. Very comprehensive. I echo similar efforts in Kalamazoo and likely most other kind of county health departments or health districts. So, I mean, oftentimes I think about, who is eligible and then who is prioritized for the vaccine. As we know, the advisory committee on immunization practices met and made their final recommendations just not too long ago, last week or so, and that helps guide next steps and where to go. An important part of that too is the corollary of the ethical principles of vaccine distribution, and also making sure that health equity is achieved by reaching those who need it most, but also in a time when there is a limited resource. And that's going to be, that's a challenge whenever there's a limited resource, but it's a particularly challenge when you're in the middle of a pandemic. And so as Dr. Bora mentioned, there is a significant amount of community engagement and communications that is essential and parallel to any of the logistics or operations part of actual distribution or planning. So most health departments are at least familiar with incident command. And I think that's going to be an important part of any type of mass vaccination planning, particularly at the volume that will be required for this vaccine, and 2 doses. That's a lot that comes with that type of planning, understanding who's eligible, and then planning all the logistics that come along with the vaccine, which at this time will be a federal asset. So anytime a health department or any entity agrees to receive the vaccine from the CDC, they're agreeing to apply those ethical principles, but then assure that the vaccine is stored properly, it's administered properly, and then it's documented properly. And that's a huge effort just in itself. And we physicians know about documentation and all the pains that come with that. But for public health in this effort, it actually is very important because we want to know who got what vaccine when, because the timing is going to be important, as is the product is going to be important as well. And so it's also thinking about, planning for it to vaccinate ourselves as local health departments. And I think about, my dad's a pastor, my mom's a nurse. And my dad always gave the analogy, like if you're on the airplane, and something's going wrong, he'd be the guy that kind of jumps up to help out. But my mom, as a nurse, savvy, will put on her oxygen first and then help others. And I think that that's true of thinking about our first line responders and why they are prioritized, our hospitals, why they are prioritized, and local health departments. And then in addition to our most vulnerable citizens in long-term care facilities, such as skilled nursing facilities. And so all of that is happening simultaneously, and that engagement with our community partners, as Dr. Bora mentioned, is key. I was on a phone call today with both our health systems, our FQHC, our medical school, our Office of Emergency Management, our own internal staff. Those are the types of, that's what we do in public health. We convene a lot of times as well as respond. So I'll pause there.
Yeah. So I guess, let's just talk specifics if we can. When it comes to the vaccines, do we know how many doses are going to be allocated to Michigan? And then I guess who's allocating them? Pfizer, Moderna are the two ones that are, I think, approved at this point for distribution. And then how are they getting distributed within the state? And then specifically after that, as a third add-on to the question, is it where is it going to be administered? Hospitals versus health departments or somewhere else?
I can tell you what I know, and maybe Willie can fill in the gaps of what I don't know. So what I've heard, and if I'm wrong too, jump in, but is that 86,400 doses of the Pfizer vaccine will be coming to Michigan. What allotment of that goes to each county is determined by the state. We don't know specifically how much is allocated to different sectors, for example, hospitals or long-term care. And then the distribution will happen, it really depends on which area you're in. But for example, hospitals will be responsible for vaccinating their own staff. Health department will be doing EMS, and then pharmacies, like I mentioned before, will be doing the long-term care. They'll be doing what we've heard is they'll be doing 3 visits to the skilled nursing facilities to vaccinate all residents and staff.
I guess to follow up real quickly. So when you say 86,000 doses, are those 86,000 individuals, or is that 43,000 people who'll be vaccinated?
No, that's 86,400 individuals. We have been told that the second dose is being held in reserve in the federal level, and so that we'll be guaranteed to get that after that. So there will be more shipments in the future. We just don't know how much and exactly when. And then Moderna should come pretty quickly with, close to 200,000 doses for the state.
I think it's going to be a moving target too. I anticipate, hearing on some calls this week about changes in terms of what local health departments receive versus hospitals versus long-term care based on ACIP, the Advisory Committee's immunization practices, including long-term care in phase 1A. So that may change the distribution a little bit differently. A big part of that is how what allotment can come at once from Pfizer versus Moderna, and the storage requirements for each one of those vaccines. That's a kind of
we've never seen before. Do you want to see it?
I guess I can share some of those details if that's helpful. So for example, the Pfizer vaccine comes in shipments of 975 doses. So that takes a facility to be able to handle that amount of vaccine. And then it's very specific. As we know, these mRNA vaccines are very specific in terms of cold chain. We're talking negative 70 degrees Celsius. That's not your normal freezer. And so as you've heard in the news and otherwise, those types of freezers have been shipped to some local health departments, such as Kalamazoo and Kent County, and the hospitals and other places are procuring them as well. But as we know in our county health departments, our immunization action programs, it's really have to make sure that those machines work, making sure that they stay at the temperature that they're designed to and that they're monitored for a week or so at a stable temperature before even putting vaccine in place. All of those types of operational details are really where multiple folks within the health department have different responsibilities of that type of procurement and those type of operations. The Moderna vaccine can be held at a lower temperature that's going to be much more amenable to smaller distribution sites. And also it's going to kind of come in smaller allotments, such as 100, which can be much more manageable and maybe get out to more rural areas, more accessible than, again, a 975 dose that requires -7 degrees Celsius, such as the Pfizer vaccine.
Yeah, I mean, the logistics of it are obviously super complicated. Um, I think people probably could understand how a hospital is going to distribute it as far, to your employees, and you probably could figure out a way of doing that. How does the health department, because obviously most people are not working at the health department. When you mention you're vaccinating EMS, personnel and first responders, how are you going to work on doing that? And also I've heard that when it comes to when you crack a vial, you've got to use them, you got to administer it within a certain period of time. And we certainly don't want to waste something that's so, in such high demand right now. How do you plan on working that out so you don't waste doses and you get it administered where it needs to go?
I think we're going to be pretty strict with the scheduling system, especially for EMS. When you get to general public, it'll be different, but for now, we'll have pretty strict scheduling to make sure people are, we can screen for symptoms, make sure we're not having people who are sick or potentially have COVID walking in the building, and really doing a dry run, making sure that our processes are quick and efficient so that we can get enough people through. Our goal is to get 40 people through per hour with the staff that we have. Because we do want to minimize time for sure with, in the COVID world, we don't want people in one area for a long time. But with that, we feel like we can get through the vaccine in the time that's needed without having it, unrefrigerated for too long.
Yes, and that part of it is understanding our populations who are eligible and then populations who are amenable to receiving the vaccine. And those are different. And I think that's why that community engagement is important to know. And I think it will be different before and after the FDA issues an emergency use authorization and ACIP makes its final recommendation. And each population is different. Let's take our own population, the group here on this call, physicians, physician scientists may be reluctant to receive the vaccine until perhaps they themselves have read their package insert and read the ACIP guidelines for themselves. Much different population than another who may have a much more lack of trust for institutions, for scientific process, or may have heard something on social media. So each of those groups is a little bit different. And the timing as we kind of roll out, I think there'll be those early adopters, those, mid adopters, and then the latecomers. And that's just going to be that continuous engagement and communication that's going to come along with the actual planning of the actual putting doses into people's arms, for example. Just as important as knowing the ins and outs of the storage and administration is going to be the communication.
Right. I mean, it is interesting because you have I guess I'll say a limited resource, and that there's going to be certainly a lot of people clamoring to get something that is going to be difficult for them to get. They don't qualify initially. And then you have a population that is going to be very resistant to it. I mean, you almost it's like two sorts of groups that are competing interests, I guess. I know you mentioned that you've got a public affairs group that's working this. I mean, obviously the public will not be getting this right away. It'll be as you mentioned, the direction will be towards people who are care personnel and then people in the nursing skilled care. How do you look to sort of, I don't know what to say, fix the problem, but how do you work to plan a messaging to get people to adopt and feel comfortable getting the vaccine when much of the message initially for people who are skeptical is that this is rushed through? I mean, that's always like the first thing I hear from even people within the hospital, nurses and other physicians.
Well, I think listening first is going to be important. So I think the conversations I'm having within our own department is having an open-ended, non-judgmental, ask your questions. If you want to do it anonymously first, kind of open seminar between our nursing staff, all the folks who are eligible for vaccination, and have that judgment-free kind of conversation with physician leadership, but also nursing leadership. Our nurses are the most trusted healthcare folks that we have, and maybe one of the most trusted professionals that we have that we can utilize. So I think that listening is going to be very important, particularly within our phase 1A, and we can we can use what we learn there as we continue to engage other populations.
And I think, similarly, I think we've been working with a lot of different racial ethnic groups since the pandemic started, and we have weekly or monthly conversations with a lot of different groups, and we've been talking about vaccine for months. And I think just as we learn more, we're really just trying to commit to transparency. And as much as we know, we will share that information. We don't want to try to, push people one way or another, but we just want to share the data that we have. And when we feel confident, we'll share that we feel confident. We also, as part of our messaging, so we've had 15 interviews with 18 different community leaders so far. And as part of that, we all, a group of us publicly committed to getting the vaccine. And then we heard from leaders that they said, we really need to see healthcare and public health leaders getting the vaccine for us to feel like it's something that's safe for us to do. And one of our nurses is our liaison to the Hispanic community. And she goes and does radio interviews and newspaper interviews a lot. And she also heard was that we need to see our leaders getting the vaccine, and some of their leaders committed as well to say, we want to publicly get the vaccine so that we can share with our community that this is the way to end the pandemic and the way to keep your family safe. So we really, go ahead. No, that's all.
Oh, no, I guess one of the questions asked, I think is one that kind of naturally comes in next is, so when it comes to administering, I know you mentioned that the tier 1, there's going to be multiple tiers of people who are getting this vaccine, and tier 1 is obviously first. Can you describe specifically what that means? I mean, because I think, if you say, well, you're a healthcare provider, well, that's really sort of a broad group. So what is specifically is tier 1? And does it matter if you're employed versus an independent physician with, let's say, a practice of just 2 or 3 docs and with their patients?
So I don't think that the tiers are completely set in stone yet. And I think there's still room for that to change. I can tell you what my understanding is from our last state call, but again, that might change. So what I have this is just from my notes. So tier 2 is state psych facilities, homes for the aged, AFC homes, and home health agencies and staff. And then tier 3 is healthcare workers that are doing procedures. So like dentists, gastroenterologists, people who are close to patients for a prolonged period of time. And then it's all other outpatient healthcare workers. And then the next one is indirect care providers. So that's all within 1A, but those are the 3 different tiers. And so I don't think we'll necessarily know exactly when we can move from one to the next, because I'm not quite sure that we have a way to know that every single, for example, ED staff has been vaccinated before we can move on. So I think it's probably some of it will be happening in parallel. Is my understanding.
Yes. Yeah, I agree. And, before those 2, so there's phase 1, and then there's those different tiers in there. And, at the top are the hospital inpatient personnel and EMS, in addition to the others that were mentioned. And there's going to be overlap as hospitals vaccinate their staff, local health departments vaccinate their staff, and as EMS get vaccinated, there is going to be, it's not like I got to think about my physics course, those series circuits versus the parallel circuits. It's going to be those parallel and some overlap. And I think it's probably good to think about it too, maybe as an upside down like funnel, that it's may come quickly and then be a relatively small amount in terms of populations, and then kind of open up into that funnel in terms of volume that is being able to be distributed.
So once we get past healthcare providers, we're talking about high-risk individuals, right? We're talking about elderly people in nursing homes. And then when does it get to the college student, I guess, is maybe a simple question. Maybe not simple.
That I don't know, actually, because 1B after that is essential workers. And then 1C is those with high-risk conditions and 65 and above. And then after that, I think, is general public.
Yeah, phase 2 is going to be is a huge population. And that's going to be your essential workers, critical workforces. And that's your fire, your police, your grocery workers. I mean, those are food, like one of those buckets is food and agriculture, and that's huge. So I think, someone like it's based on risk of exposure and also risk of complications. And those are different, but help guide some of those those principles of using a limited resource. So college students, for example, are are a population that has less risk for serious complications. And although they may live in a congregate setting, they're not a member of a critical workforce to make sure that our things happen. So I anticipate that's going to be late spring when those folks begin to be vaccinated. Now, those who are teaching, our educators are likely to fall in that phase too, that very large population to be able to execute a learning environment. Would be different than those who are then receiving or being recipients of information in that learning environment. And so this is also good to, bringing that up. This is going to be a marathon. There's going to be sprints within this marathon. And so I think those expectations are important too. People hear a vaccine's coming, and that is obviously true. But we're going to be vaccinating. So public health is going to be vaccinated. Healthcare is going to be vaccinating well into 2021.
So I feel like our ethical help is really valuable, because how do you decide in a category of essential workers who's first, who's second? That's just a really tough call to make. So we are meeting with an ethicist on a regular basis to just to make sure that we are thinking clearly and have that outside perspective as we go forward. And he's also, the ethicist we're using is also part of the West Michigan Vaccine Collaborative, and at every one of those meetings. So I'm grateful for that.
Yeah. I'd like to remind everyone that if you have questions, just go to the chat function and you can type them in there. One of the questions we got is, I guess, this sort of goes along the lines of how we convince people, or certainly make sure we include everyone in the plan, and what specifically is being done for, and I think you touched on it briefly, Dr. Bora, but what specifically is being done to help vaccinate poor people of color, or, people who might have more difficult access to healthcare?
I think those are things that we'll need to consider once we get into those, after this initial phase of vaccine, but, really thinking about mobile vaccination, vaccinating at different sites. We've heard already that people want vaccinations at neutral sites that are not government entities or anything like that. So I think really listening, like Will was saying, we just need to listen to what people are, what they trust and what is feasible. So if it's a refrigerator vaccine, it's going to be much easier to do different vaccination events, be on site at different places than it will be with, like, for example, Pfizer. That would not be a possibility. And then, really making sure that people know their rights and know that, the administration fee should be covered by insurance. It will be covered even if you're uninsured. The actual vaccine has no cost. And so how do we make sure that people are aware that they shouldn't be having additional fees, just for getting vaccinated?
Yeah, that question about health equity is very important, and it's also should ideally filter in how we think about distributing a vaccine. We can think about, if you think about a mass vaccination clinic. If, say, it's cold outside, this is going to be January. Hey, we're going to have a mass vaccination clinic at the mall for this particular population of folks, and coordinate that effort. I mean, that's part of most local and state public health departments' mass pandemic vaccination planning, even going back to H1N1, for example. Well, thinking about that is, well, okay, you have to get out that message to reach a certain population. You have to have a car, to show up at that type of event. If you want to pre-register those folks to make a more efficient process, well, you got to have internet or a phone or a computer to do that. And that leaves out a significant, part of a population. So even thinking about how to distribute that vaccine should be influenced by thinking about those concepts of health equity. And then there are those, for example, who may have those resources, but they may not be able to come to you or us, however you want to characterize that. So we think about those who may not be living in a skilled nursing facility, may not be in adult foster care, but maybe live in a senior living complex, okay? And they are a medically vulnerable population, but it can't come to you. We have to go to them. That's also thinking about those vulnerable populations and getting the vaccine to those who are vulnerable and those who desire to have it.
Thanks. And that brings up another question on that. Do you have a plan for the booster dose? Because, if you had, let's say, a big vaccination at the mall, theoretically 3 weeks later, everyone should come back for that second one. So how is that going to be, how are you going to plan to communicate? I know that's probably further down the future because healthcare workers and people who are sort of captives are a little bit easier. We have a place where you can kind of come to their place of employment. But what are the thoughts for making sure that people aren't lost to follow-up?
We're trying to schedule the follow-up the same day and have a clinic planned 3 weeks later. We don't know enough information about how much wiggle room is there. Can you be 4 weeks? We just don't have any of that yet. So until we get more information, we're going to have to assume that it needs to be exactly 3 weeks. So that's what we're going to try. And people will have vaccination cards. So hopefully we can keep track that way and reminders.
Yeah. So this goes to another question and now we'll kind of get into maybe specifics that you may or may not have answers to. And I'm guessing not to some of them, but when it comes to fertility, there have been some questions about fertility issues that might happen to young females by taking this vaccine. Any information on that you have that put people at ease or make them, I guess, be concerned?
Well, part of that is, it's very tempting for me to, look at some of the peer-reviewed data on some of the vaccines that have already come out, or speculate. But I'm cautious before even doing that, because what I'm really waiting for as a county medical officer is for the FDA EUA, so I can review the package insert and then also review ACIP's recommendations. That's the role of ACIP, Advisory Committee of Immunization Practices, is to present data and make recommendations for who is eligible and how to manage the vaccine. And that's an independent panel of experts outside of government, outside of CDC, but are members of our profession as well. So I'm looking to synthesize both of those significant information reports that then will inform recommendations that I make to our community. And when that comes out too, there's also engagement within our peers. Nirali and I have a great set of peers as county medical directors, as we have peers on this phone call in the wider medical community where those conversations can occur as well. But those are two key data points I'm looking for: the package insert and ACIP's recommendations, because we want to be confident in the information that we are presenting, particularly confident and transparent, particularly when this is new.
And then to that point that it's new, I mean, you hear people say all the time that it's a novel vaccine. It's because it's using messenger RNA. How novel is it? I mean, my impression is, at least with the delivery device, there are different ways of getting the messenger RNA into the cells to start the process. But can you speak to that?
I guess I feel like it's been in development for a long time. So I think the method is new, but the principle is what vaccines are built on. And honestly, it's not a live virus, so it's a much lower risk than many other vaccine mechanisms. And just the people have gotten, I think, is, oh, sorry, go ahead, Will.
No, go ahead.
I just think the efficacy that we're seeing so far is pretty remarkable for a vaccine. And so I think using the mRNA principles to do this, where we kind of just hijack the cell and make high volume of protein, I think it's a very effective mechanism. But I think people worry that it's been so rushed, but it has been under development for a really long time. I think now that they had the resources to get it to this point, allowed it to happen, but I think it also opens the door for so many more potential vaccines in the future.
Yes, and I agree with everything that kind of Nirali has mentioned. And there is a nice article that I'm going to put in the chat from, pulling it up here, JAMA, on specifically mRNA vaccines that provides a nice kind of overview. So I'm going to pull this up here and go ahead and put it in the chat.
Yeah, I think certainly some of the terminology that's been used has been confusing and can certainly be misconstrued. When the discussion about we're going to rush this vaccine or get it through as fast as possible certainly gives people the impression that there's not been any testing or adequate testing. And I think when it comes to Operation Warp Speed, at least from what I can understand, it pretty much was we're just pre-purchasing vaccine doses, and it's primarily the sort of the speeding up of the process with the vaccine development, which makes it much cheaper, I guess, at least from a risk standpoint from the company to actually produce these vaccines, right? I mean, that was pretty much the impetus from the government. It wasn't to skip phase 1, phase 2, or phase 3 trials.
Yeah, I think it's kind of it highlights the point of how important communication is, just as important as the actual science or administration in itself. And Nirali and I live that every day,
Sure.
particularly with every population or community member we engage with. And that's important when we're thinking about engaging our well, you know, are we engaging our schools, our hospitals, those are two key, or homeless shelter leaders. All those populations are very different. And it's just understanding, kind of meeting folks kind of where they're coming from.
So I'd like to pivot a little bit since we don't have any of the questions. Again, if you have questions, just feel free to type something in the chat and we'll get to that. So my question goes to schools, because my wife's a pediatrician, so she gets a couple questions occasionally about school. That's a joke, of course. She gets it all the time. When it comes to the schools, and Kent County just recently issued a guidelines, I guess we'll call them. I think that's probably the right term, for school closures, opening, ways you administer education, whether it's virtual, some hybrid, or I guess just sort of normal. That's been under development for quite some time. And I guess the way it's listed, and obviously doesn't supersede the state rule. So the Michigan Department of Health and Human Services says no high school. So there's only, so the Kent County doesn't actually change that. But like we have 4 levels: green through yellow, red, orange, and red. And it looks at the positivity rate in the community as a rolling 7-day average, as a guideline to try and determine what level you're in. And this goes also not only just for schooling, but also for extracurricular activities. And so it depends on sort of what you get. Maybe I'll try, and I don't know if I'm as savvy as Dr. Nettleton to actually be able to put it in the chat, but I'll try. The thresholds are less than 5% makes it green, 5 to 8 is yellow, 8 to 10 is orange, and over 10 is red. So we've been in the red for quite a while now. But do you feel like the positivity rate is the best way? Because I only ask that because when you're trying to figure out how much is in the community, we had Spectrum Health, which is recently, and I don't think they've changed this, was just testing people who were symptomatic. So it would naturally make your positivity rate higher than it would be if you're just testing anybody who says they want to test. Is that just sort of like we're thinking that's the best thing we can probably do because it's sort of a crude tool? Or what's the thinking behind that? And do you think that's the best method? I guess is my question.
So yeah, no, probably not. I mean, incidence is probably going to be a better measure to use. When we started developing this, though, we did have more adequate testing in the community. And so at that point, it seemed to make the most sense.
Sure.
We'd been talking with a lot of different folks in the process of developing it. And since it's an easy to access indicator on our dashboard, we felt like it was a good place to start. So again, not completely ideal, but it's somewhere to begin.
Sure. Any other questions in the community there about the vaccine? Or is there anything that we haven't talked about that you'd think would be useful for our physicians to know?
One thought that I've had is, I think, we physicians, when we communicate between each other, or maybe even to our patients, our bias perhaps is that we believe that we can change minds based on communicating what is fact and what is based on science. And that's just our go-to. That's who we are. That's who we're wired to be. That's how we are trained. And I think what we're going to find, or what we often find in public health, is that it's the relationships that and ongoing listening and conversations, and then adjusting communications and strategies that will have more persuasion than saying, this is how it works, and this is why it works, and this is why you should get it. I think that's something that that we're going to continue to find, particularly in this day and age of social media and distrust of authority and institutions.
Yeah, and I would echo that. I see plenty of physicians, nurses. I don't know if condescending is the right term, but it certainly seems like I know better, and so you should just do it, and not trying to sort of meet people where they are, which is, I think, part of what you're talking about, the community involvement, engagement with various populations to try and find out what their concerns are and addressing them, versus kind of just telling people, you just almost a paternalistic sort of look at it.
I guess I'm also curious to hear from this group on what would be helpful to hear from us. I feel like we have not done a great job of communicating, at least in King County, what we know about vaccines, and we're trying, but we're really not doing a good job. So if, I'd love to hear what would be helpful. And we've also heard about providers who don't trust the vaccine and are hesitant to recommend it. And I understand that too, but, however we can help in that, we'd be happy to.
Yeah, so I find it interesting. I'll just be the first one to jump out here, that I have nurses all the time ask me if they think it's a good idea to get it. And it surprises me because these are not people who are normally skeptical of vaccinations, but they've certainly heard all the potential differences or problems, and they have family members asking them, because they're maybe they're the healthcare person in their immediate family or an extended family. And so they're really concerned about the terminology, fast development, it's novel virus or vaccine. I guess that's the hesitancy I get from people within who I think, would have the most information, or at least the easiest access to it. So I'll read a question here. So any thoughts on the AstraZeneca product? So so the Pfizer and Moderna vaccines are the ones that are going to be are the ones who are going to be hit us first, let's say, right, in the next couple of weeks. But AstraZeneca has one, and their effectiveness was much lower, but they found that by accidentally giving a half dose, which sounds like it was a mistake with the administration in the trial, and then a full dose for the booster, that people actually had a better response than the full dose. Do you have any thoughts on that? Or, I mean, I think we all could just speculate, I suppose, but I don't know if have anything new to add to that.
I have nothing to add to that.
Yeah, there's a reason we didn't go to immunology, right? I don't think anyone totally understands how the immune system works, but interesting, right? I don't know. Anyone else have any questions or about the vaccine or distribution?
I mean, I think it's going to be important for public health and physicians to also set expectations that for those who do, this is another tool in a toolbox. I do like that Swiss cheese model. I think it's effective in communicating how all the interventions that we have been communicating provide additional risk reduction. So social distancing, wearing a face mask, avoiding being in crowded indoor places. If you meet outside. If you meet, be greater than 6 feet. And add on to that now a safe and highly effective vaccine. It's going to be important that these are all tools to reduce risk, and that individual risk is different than population risk. And so it'd be for some in the population to feel, oh, some people are getting vaccinated now, so therefore I can not do all these other things because it's going to be safer, would be a mistake, because this is about reducing risk on a population level. We're going to be needing to social distance, wear face masks, do all these things we're doing well into 2021. So it's just important, I think, to think about that and set those expectations too.
Yeah, I guess that gets me to one question, I guess, when it comes to the vaccine. We don't know if it's a sterilizing vaccine, which means that it's entirely possible that these individuals, I think, were infected with SARS-CoV-2, but never exhibited any symptoms. And then so the vaccine was effective in the sense that they didn't develop COVID-19, where they are symptomatic and had required hospitalization. But it's possible that they got it, were infected, maybe even transmitted to others, but they just didn't exhibit any signs of that. I mean, is that accurate as far as you know?
Can you say that? What, are you asking?
So I guess the question is, do we know if, because my understanding is we don't know that people were actually sterilized from getting infected. Like, if you're exposed, does the vaccine prevent you from getting an infection, or does it just prevent you if you get an infection that you don't exhibit any signs? So you basically don't, you get infected with SARS-CoV-2, you have it, but you don't actually get COVID-19, but potentially you could still transmit it. Those are the things we don't know at this point. Is that correct?
Yeah, I think we don't know that for sure. Yeah, that's the hope, but yeah, we don't know. I think the AstraZeneca one was where they were thinking that they may have more understanding that there was less transmission happening. But yeah, I don't know any more than that. So
yeah.
I have a question. This is David McGrath. I'm an internal medicine doctor in town. It seems like the numbers of new cases in the community are leveling off recently. Is this correct? And if so, do you attribute that largely to schools going virtual to a much greater extent recently?
So yeah, we have seen a decrease in the last few days. I'm not quite sure what to attribute that to. I do know we have less testing. It could be partly because we have high schools virtual right now. We are seeing a decrease in our numbers in school age in general. We are seeing a decrease in positivity there. Fewer cases have been reported in the past week or so in that age group. So I think it is possible. Perhaps people are not dining in restaurants quite as much. All of those things, we may be seeing an impact of that as well right now.
Yeah, I'm always cautious too when communicating trends in a press release or in a press conference, because there is, thinking in terms of 7 days versus 14 days in terms of a maximum incubation of SARS-CoV-2. And, acknowledging that there are a lot of factors that contribute to even a decrease. So this is where just communication is also really important too. So you can have a significant decrease, but still remain really high for an elevated level of virus circulating in the community. So it's the context as well. And we find that often to be a challenging communication where, hey, there has been a decrease, but past in our epidemic curve, we've still been at a very high elevated risk of virus circulating in the community.
When do you expect to know the distribution plans for the state of Michigan? How much goes to Kalamazoo, how much goes to Grand Rapids, et cetera?
I think Friday we will know, is my understanding. I think the vaccine has already been sent to certain areas throughout the state and is waiting for the FDA review. At least that's my understanding.
Yeah, like everything else in this pandemic, I could say something at 8 o'clock in the morning and then 8 o'clock in the afternoon is completely changed. And that's happened multiple times throughout the pandemic. But a part of the strategy at a national level has been, to pre-place some vaccine in freezers strategically throughout the country, throughout the state, even prior to FDA emergency use authorization. So when it is authorized, then it can be in place and ready to distribute.
Well, I think we're near the end of our questions, and I want to thank you both for coming on and telling us what's going on in Kalamazoo and Kent counties. And do you have any parting words, or I think we've kind of covered about everything that we know at this point, probably, right?
No, I think if people have suggestions or thoughts or things that we could improve on, I would appreciate an email. So I'd love to hear from colleagues on their perspective on how things are going. Sometimes I do feel kind of stuck in my world. I don't always know what's happening or what people are thinking. I have a regular group of physicians I speak with, but not all of you. So I would appreciate that.
Yeah, I echo that. And I do really think that, physician voices in the community are always important, even in routine times, but particularly important during a pandemic, particularly when there is so much misinformation out there and distrust in institutions and in places of authority.
Okay, so thank you so much for your insights and for what's going on. I think that people probably learned quite a bit, and maybe we'll have to have another discussion in a couple weeks to see sort of how things, because I mean, at that point, well, like you said, it'd be totally different, right? In a couple weeks from now. Before everyone signs off, we have the most exciting part of the night. Well, the most exciting thing is me getting away from my fire, which is, I think, about 2,000 degrees right now, and I'm getting close to being a puddle. But we're going to go to the wheel. I've been working feverishly to try and get everyone's name on this wheel and see if I can share the screen, which it didn't work last time, but I think we're gonna pull it off this time. And we're gonna find our door prizes. And let's see, I think that's there. So I just typed as fast as I could. There might be typos or whatever. We're gonna do this twice. And here we go.
Your name says Eric Larson, not Pat Sajak, you know?
Yeah. Patty's my Vanna White, but we'll see. We're gonna see if I can find out. I've got the irony here is that the Zoom thing goes over it, so I can't actually spin it here. Oh, here we go. All right. This is very exciting. This has taken us 6 episodes to finally figure out how to do this. Dr. Demagd. Congratulations. Okay. And now I'm actually going to remove it. So now the nice thing is, since Dr. Demagd has been removed from the list here, everyone has a better chance of winning. Oh, actually, I think it did it automatically. That's nice. Here we go. And for the number 2. Oh, I thought we were going to have the anesthesia. Just missed. We had an anesthesia sweep. Dr. Apple just missed out. So Dr. Jackson, congratulations. All right. I get back to the screen here.
Dr. Larson, there's one last question.
Oh, okay. Oh, yes. Can you provide your emails to everyone so that these docs can get a hold of you, Dr. Bora and Nettleton? If you want to just actually type it in the chat, that might be the easiest thing. Just kind of put it to everyone. And then if you want to stay on, you can find out, you can get their emails, you can write them down. Wow, you are fast, Will. I'm impressed. That's like, so again, I'd like to thank everyone for joining us tonight for the Fireside Chat. I hope you found this useful. Please contact us at info@kcms.org, and you can, with ideas for future chats, we'll try and stay up to date and find things that are helpful. You can find the recording of this and all the previous discussions at kcms.org. They're YouTube, so again, they're all recorded. And I would encourage you, if you're not a member of the Michigan State Medical Society or your county medical society, please join and encourage your colleagues and to join as well. It's, I think, a great opportunity to become better informed, become better physicians, to work together for common purposes. And with that, I'd like to also thank the Kent County Medical Foundation for providing the gift and door prizes for us today. So thanks so much for everyone. I'm going to turn off my fireplace before I melt. Thanks.
Thank you.
Thank you.
Good night.
Good night.
Good night.
Thank you.
Thank you so much.